Thank you all so much for joining us today. Also, thank you so much if you are joining us from Symposium. Thank you for spending the day with us. We are very excited to have you all here. Welcome to the program working with people who use drugs, understanding stigma, with our speakers Tanagra, Melgarejo, and Joe Pereira. Please listen carefully to the following instructions. This webinar will run from 6 to 7:30, and this webinar is worth 1.5 CEUs. All participants will be muted throughout the full duration of the program. Feel free to add your questions and comments in the chat. Both the monitor and speakers will be monitoring the chat. The last 15 minutes will be reserved for Q&A, but there will be Q&A happening as we are going through the presentation. There will also be a code given at the end of this webinar, so please do not leave the room without this code. I will make sure to also add the code in the chat. And please note that this webinar is being recorded as well and will be posted to the Social Institute of NASW. Thank you so much again for joining us. If you have any questions, please include them in the chat. And I am now passing the mic to the presenters.
Good evening, everyone. My name is Julie Burns, and I'm the president and CEO of the RIZE Massachusetts Foundation. I'd like to welcome you to tonight's session. This is the first of two focused on the vital role social workers can play in helping to end the overdose crisis. Thank you to the National Association of Social Workers Massachusetts chapter and the National Harm Reduction Coalition for partnering with us on this important initiative. We're grateful for your leadership and shared sense of urgency in our fight to save lives. There are too many people to name, but it's been an honor and a privilege working with the teams from these two organizations. Next slide, please. I'd like to take a minute to tell you a little bit about RIZE. Launched in 2017, we are the only public-private partnership dedicated solely to funding and creating solutions to end the overdose crisis. Guided by those with lived experience and unafraid of new ideas, RIZE is building networks, designing programming, and supporting community partners who are using novel approaches to preventing overdose. Since our launch, we have invested close to $10 million in organizations across Massachusetts. We're made up of a group of constantly growing group of providers, payers, unions, advocates, and people with lived experience who are equity-minded, entrepreneurial, collaborative, and dogged in pursuit of our mission. Next slide, please. Despite the existence of effective treatment for opioid use disorder, only a minority of affected individuals receive treatment each year. This is due to a range of issues, including stigma, disparities in access to care, and the design of some treatment programs which may be unwelcoming to certain populations. Ironically, individuals at highest risk of harm are least able to access care. As the crisis continues to take a devastating toll, we at RIZE believe that strategic workforce investments will ensure that professionals, like social workers, who provide critical direct care are given the tools and resources necessary to meet the needs of their clients experiencing opioid use disorder. Harm reduction is one of those tools. It's focused on keeping people safe and alive for as long as possible, whether or not their ultimate goal is recovery. And research has clearly shown that many people using harm reduction services would be interested in treatment if it were more readily available and delivered in a more person-centered model. Next slide, please. When we embarked on this idea, we knew we needed experts from both fields, social work and harm reduction, and we're so proud of the groundbreaking partnership we've built with the National Harm Reduction Coalition and the National Association of Social Workers. This series, led by National Harm Reduction Coalition's Tanagra, Melgarejo, and Joe Pereira of Outlook Associates of New England, will provide important information about harm reduction practices and the barriers and limitations that stigma can present when developing meaningful relationships with clients. Through this initiative, we also hope to create space for dialogue and learning with the goal of providing enhanced care for those with opioid use disorder. Thank you for being here, and thank you for the work you do every day to help stem this crisis. But before I turn it over to the experts, I'd like to share a video from Nashley, a social work graduate student and one of our Heart Scholars, a paid internship program for second-year Master of Social Work students who are doing training in harm reduction settings. You've all heard the saying that sometimes you're the teacher and sometimes you're the student. And in this case, I think the student can teach us all a little something. Please enjoy the video.
I think the role of social workers in combating the overdose crisis is really just a lot of is reducing the stigma, whether it's stigma from the community towards people with SUD and OUD, or even the self-stigma that comes with it, and the shame that comes with having these disorders. So social workers can really benefit from learning about harm reduction, so that way we can empower our clients to seek the help that they need and to really take back their lives from these devastating disorders. Coming in as a graduate student that's learning this, I'm able to even bring it into programs that have already been established by even just opening that dialogue. What is harm reduction? Where can we use it? How can we use it? And really just starting with the fact that harm reduction is something that can be used to empower people, rather than looking at mental health as we are the providers and we know what's best. We're putting the power back in the hands of the clients and letting them know you are the master of your own destiny. We're just here to empower you to realize that yourself. I became a social worker because not only have I had personal experience in recovery and in mental health, but during that journey of mine, I didn't have a lot of representation in the voices that were speaking for me. So I decided once I did my own healing that I would enter the field of social work and be able to show someone that healing is possible and healing for someone that looks like me is possible.
Tanagra, it's over to you and Joe. Thank you.
Thank you, Julie. I have to say, I wish I had the opportunity when I was studying social work to have NASW's opportunity to and to have been able to think about harm reduction and the application of harm reduction as a social worker. And I'm grateful to the work that you're doing in supporting us in thinking about this as social workers. Thank you. And thank you for the opportunity to be in community with all of you tonight. I'm really excited. And I have to say it's a little nerve-wracking because a lot of folks here, which is great. But also, the first 5 minutes is always a little, te pones nerviosa, as we say in Spanish. So I'm really thrilled to be in community with you today and with my co-facilitator, Joe Pereira. And we're going to be talking with you all about, what it means to work with people who use drugs, particularly understanding the impact of stigma and folks' ability to access services and to be able to connect with us as providers. And I think Joanna are going to introduce ourselves in a second, but before we do that, I just want to make sure that if anybody is having any accessibility issues, please, you can direct message Chris Belly, Joe, or myself. We will try to support the best way that we can. And we will be using the Zoom closed captions through this training as well. So those should be, you should be able to see those. I apologize for what Zoom does sometimes with my accent. It will change words. So if you see something funky, it's Zoom's fault. As Julie mentioned, I am part of the National Harm Reduction Coalition. I've been with National Harm Reduction Coalition for the past 5 years, and but we've been in existence for much longer. National Harm Reduction Coalition began out of Oakland, California, and it was organized by a group of folks with lived experience that were being impacted by the HIV pandemic at the time, and they were being left out of conversations that were happening at the national state levels in regards as to what to do with this pandemic, what policies and practices that we want to put in place to make sure that we could address it. And so in light of not being included, they decided to organize and to push for change. And since 1990 something, we've been creating spaces for dialogue and action that can help heal the harms of racialized drug policies. And we do that through any of these different avenues. If you're curious about National Harm Reduction Coalition, if you have any questions, please reach out to me. You have my email. I'm happy to connect and make sure that I am able to point you in the right direction. We also have a conference coming up here in Puerto Rico, which is where I'm based out of. I'm really excited. It's happening in October. If you're interested in attending the conference, please visit our website and you can find more information as to how to do that. It's the first time in more than 3 years that the National Harm Reduction Community will be together in one place. We're really looking forward to seeing each other. It is a really exciting space to be because you're amongst about 2,000 other harm reductionists from across the United States and the world. It is a beautiful space of community. So if this is something that interests you, I would encourage you to come here so I can meet you in person in Puerto Rico. I think Chris Belli went over some of these things already. We definitely want to encourage folks to use the chat box to add thoughts, questions, comments. There will also be a space where folks at the end can ask questions also, but you don't have to hold those until then. So if there's something that you want us to check out, please, you can certainly use the chat box to ask questions. And I think there's a feature where you can raise your hand, but there's a lot of us here, it's almost 270 folks. So we may make use of that, but we will have to see how it goes. And in terms of what we're hoping to accomplish today, we will start by defining stigma, look at what is stigma and how does stigma show up in our work. And then we'll move into a conversation around the elements and functions of stigma, exploring particularly how society operationalizes stigma. And then we'll move to creating change, right? How do we shift this? How do we think of ourselves in our practice as folks that are committed to dismantling stigma? And we can envision a world that can exist without a stigma. If that world existed, what would it look like? And how would it be different for us as providers and for our participants? And then we'll just close out and let you go on with your evening. Hope that sounds good to you all. Awesome. And so I'm gonna pass it over to Joe.
Thank you, Tanagra. So I am so happy to be here and want to thank NASW and RIZE and the National Harm Reduction Coalition for the opportunity. I've been involved in substance use treatment, working with people with substance use treatment since I got my MSW in 1987. So yes, I'm an older person here. I am really heartened that this issue is finally getting more attention. I guess I'm cautiously optimistic that the attention to substance use issues and addiction can be sustained. I think probably for many of you who are participating, I've certainly been in my life touched by addiction issues. I have a nephew who struggles with opioid use problems, and I've had 2 children of cousins die of an overdose. So this is just really an important issue. My perspective is going to be coming from a clinical issue, the clinical side in terms of working with people one-on-one. And I think the harm reduction approach, along with motivational interviewing, has been really my guides to helping people with addiction issues. And so briefly, I'd like to lay out some of the assumptions and principles from my perspective that kind of are the harm reduction approach before we move into delving into stigma. So obviously the overall goal here is to help make treatment more appealing, engaging, and effective. Perhaps that's a common sense no-brainer, but just so people are aware, and this statistic has always sort of kind of jumped out at me, that there is some research to show that up to 10% of people in psychotherapy actually get worse in treatment. And so I think we have to pay attention to that. And so it is essential that the treatment that we do is more, causes less harm than the drug use that the person is engaging in. So basically, there are 4 principles that I just kind of like to lay out. The first one is that excessive behaviors occur along a continuum of risk. So ranging from minimal to extreme. For addictive behaviors, it's not all or nothing. So it's not an all or nothing phenomenon. So our approach should take that into consideration. And so the kind of the 3 boxes here: safer techniques, manage use, and abstinence. can all be sort of options that we're working with potentially with individuals. So that's one assumption. The other assumption, I think, is whether a person uses drugs for recreation, escape, or mental enhancement, it's adaptive in many ways, that drug use is adaptive for the individual and beneficial and can continue to be so. Gabor Mate, who some of you or many of you may be familiar with, said, don't ask why the addiction, ask why the pain. And so I think that's important assumption as well. Abstinence may not be an option for people for a variety of reasons. That may be hard for us as helping professionals to kind of accept. Alan Marlott, who was one of the sort of the first people, clinicians, to really sort of delve into harm reduction, talks about pragmatic compassion. And I think that's really an important stance for people to take. And that we want to move from abstinence only into a reduction, that any reduction in harm is a step in the right direction. And so again, really important to keep in mind. And also don't, and I think this is something that I've certainly learned, don't equate that if somebody doesn't have an abstinent goal, that they're less interested in treatment. That it's very important not to sort of kind of conflate the two. That a person can be interested in treatment and getting help, even though they may not be interested in treatment. In abstinence. The last thing I would ask people to think about is, when thinking about a harm reduction approach, is the development of a needs hierarchy. So the role of social workers in working with individuals is to create a hierarchy of needs that reflect and address the most urgent concerns, the long-term goals and strategies for people who may be actively engaging in drug use. So again, we have to be really conscious of not making assumptions that, oh, this abstinence must be the only or the best way for a person to achieve these goals. And so we have to assess the many facets of their life, that clients are more than their use of drugs. They're more than their use of addiction. And we have to help them and have a dialogue with them about their values and worries in a way that creates mutual trust and respect. So there's certainly a lot more to say about harm reduction, but I think those are probably, from my perspective, 4 really key guidelines.
So there was a question in the chat box. If you could please provide the reference in regards, there's 2 questions, in regards the 10% that of folks that get worse in treatment, and then another one around the research on psychotherapy.
Okay, so I would need to, I don't have that handy. So if people can email me with that interest, I can send that out to them.
And we can also include it in the resources list. I said to folks, we can use, if we have a resources list that is ongoing and folks will have access to that, we certainly can add it there.
Yes, thank you.
And we have, Caroline is sharing, I work at a MAT program. A lot of what I talk about with patients, especially those with dual diagnosis, is harm reduction. Absolutely.
Great.
Awesome. So I really appreciate Joe's framing around harm reduction, the idea that harm reduction requires us to think of how we enter in relationship with people differently, and to really enter those relationships without expectations, right? Really being present to listen, right? And to ask questions with care and curiosity that can lead us to understand people's drive, needs, and what they derive from substance use, right? What's the things that are good for them in relationship to substance use, and the things that they may like to think, they may like to see change, if at all, right? But there's no expectation in this relationship, right? And harm reduction is also a movement, right? So it is requiring us to shift the way that we think about our relationship with folks, but also to shift the way that we think about systems, right? Harm reduction is rooted in the belief that public health equals social justice, right? That public health and the broad spectrum of public health should be accessed by everyone. Everybody should be able to have those needs met. And that there's intersections within different fields of public health, right? And the possibility of engaging in harm reduction. Harm reduction as a movement also believes, and we cannot forget that harm reduction came from people who use drugs, right? People who use drugs self-organized because their needs were not being met. And they needed those needs to be recognized, and they needed to have a voice in the development of policies and practices that would be impacting them and their communities, right? And one of the things that they said was, racism, stigma, and criminalization are the real roots of harm. They're the real true causes of harm. We cannot unsee those things, and we cannot ignore those things when we're working with folks. And we also believe that the only way that we will end inequality and oppression is if we foster the health and liberation of those that have been most impacted by the war on drugs, by the opioid crisis, by the prison industrial complex, by misogyny and capitalism and all these things that hurt and harm people. And we can do that by centering the leadership of the folks who are experts, and because those are the ones that will lead us to transformative change. And those that are experts are people who use drugs and their communities. And so when we think of harm reduction, we can think about it as a practice, but also think about it as an embodiment and also as a movement that is seeking to create changes in our society that are not only good for people that use drugs, but that are good for all of us. And I think for me, what made me fall in love with harm reduction was this, was that I could do something actively to work towards changing systems that are unequal and that are unfair, and that not only hurt people out in those systems, but also hurt me as part of those systems as a provider. And so I just wanted to share that. I also think, if we think about harm reduction, right, that we can look at harm reduction in many ways, but the most important things that I want us to take away before we get into thinking about stigma is that when we're practicing harm reduction, our goal is to maintain participant autonomy. Right? We want to make sure that folks are able to determine as much as they can where they're going or where they want to go in the process with us. And that means that we need to be flexible, right? We need to be open to people changing their mind or deciding that this is not for them, or maybe asking us to pause, right? We need to go at the speed of trust, and that speed of trust will be determined by the participants, and each participant is different, right? Harm reduction is not a one size fits all. Really is looking at each person and their circumstances. We also need to acknowledge barriers, right? What are the barriers? What are the things that are keeping people out, people away, right? That are preventing folks from coming to us or feeling that they can share their true selves in relationship with us. And we also can, by acknowledging barriers, we can also begin to not only engage in conversation with people, but to think about what are the needs that people have, right? Sometimes those barriers are connected to people's needs. So what do I want? What do I need to be able to get to the place that I want to go? And in order to do that, it's really helpful to focus on concrete steps, right? Sometimes our participants, I think you mentioned that, sometimes our people come to us because they have many things that they want to work on, right? And substance use may be one of them, but it may not be the priority, right? In that moment for that person. Maybe my priority is I'm struggling with my relationship with my partner. We're not communicating well. and this is someone who's really important to me, or I really feel that I let down my parents and I want to, figure out a way to build bridges back with them, right? And so we focus on those steps, on those concrete steps, and from there we can build, right? We can build deeper relationships with people and help them feel more empowered and strong to feel that they can then make other choices for themselves. And I see that Carissa is sharing, I am a PSS that has worked in treatment. I'm currently a harm reduction outreach worker. When I ask social workers I know in recovery to advise their clients actively using to call me to get them in a harm reduction program, I'm told that there's ethical issues with them suggesting clients seek harm reduction services. Is there any truth to ethic violations for embracing or suggesting harm reduction? And then Caroline is sharing harm reduction is ethical unless they want you to encourage active use, which is unethical. So I wonder, Joe, if you would like to, maybe as someone who is working in this field in Massachusetts, what would you respond to Carissa in regards to that?
I don't think there's an ethical. I think you mentioned somebody. Obviously, there would be ethical issues if you were encouraging people per se to use drugs. But the fact that this is, I think, social work 101 is start with the client is, and this issue that Tanagra touched on about acknowledging barriers. We don't, as clinicians, want to be a barrier. And so, again, any effort at change, any effort, I don't see where reducing a person's harm, where we get somebody to use clean needles, for instance, is unethical. It means it's reducing their harm for illness. It's reducing their spreading it to someone else, potentially hepatitis, HIV, that sort of thing. So I think that's a very ethical sort of perspective that we should be having.
Thank you, Joe. And I think if you haven't met your harm reduction program in your community yet, I would encourage you to make friends. They would love to connect and work with you and have you support their participants and vice versa. So I'm now passing it back to Joe, who's going to lead us to a conversation about what is stigma.
Thank you, Tanagra. So some of you, or many of you, may have already asked this question to yourself. But as we go through this, because I think it impacts on stigma, is to ask yourself, is it okay for people to get high, to get intoxicated? Is it permissible to alter one's consciousness for the purpose of pleasure, to relieve pain, escape from reality? But more than just asking that, we also have to ask ourselves, if so, for whom is it okay? And under what conditions? And with whose permission? So many people may say, yeah, it's okay to get intoxicated, to drink to intoxication, but not to get high, to put a needle into your arm to get high. And so we have to ask us that, because that's going to impact on how we are dealing with a person that's sitting in front of us. I think the other thing is that while I welcome the attention that the issue of the opioid crisis has occurred and it's giving us more attention, but we have to consider the context of this. That over the past few years, that the reason, a big reason for the opioid crisis has been the use of pain medications, which on some level was acceptable because people were relieving pain. And that's how they got started with their addiction. And it's been, in the beginning, maybe not so much now, a white middle class phenomenon. So in that sense, it makes it, I think, from the society as a whole, perhaps less stigmatizing. That unfortunately, one of the reasons why we have brought attention to this issue is because who the addiction has affected over the past few years. And so I think that's an important thing to think about. The other thing, so, the definition here, a social process which can reinforce relations of power and control, leads to status loss and discrimination for the stigmatized. I would just, again, some of you may be familiar, but to look at the case of Billie Holiday, the jazz singer, and her story. She became addicted to heroin. The reasons are multifaceted. One of the reasons was she was raped as a child, but also having to deal on an ongoing basis with racism, prejudice, and discrimination. The head of the Narcotics Enforcement Division at that time, a guy by the name of Harry Anslinger, was a racist. He targeted her to the extent where she was on her deathbed in the hospital, and the federal agents came into the hospital room and arrested her for drug possession. So so this is just an illustration, a pretty dramatic one, of this issue of power and control, and the issue of how this person in charge, in power, decided, and the focus was primarily on marginalized communities in terms of narcotics enforcement. So that's just sort of, and our history is just so full of these cases on a much lower level. But again, Billie Holiday is just a symbol of that sort of thing. Next slide, Tanagra. So when we think about stigma, I have a very strong CBT background. So I look at this from a context of CBT. So when we look at stereotypes or ideas, I would call those core beliefs or schemas, how we view other people. In this case, people who are drug users, excuse me. They're incapable, they're fragile, they're dangerous, they can't recover. And that leads to what are called thinking distortions, prejudices, beliefs. They are scary, they're less than. And then that leads to certain actions. And they can be sort of social, just day to day. We don't want them living next to us. We don't want them to be a coworker. We don't want them marrying into our family. And then structural. The discrimination and prejudice that people face because of their drug use. So if we think about the war on drugs and the criminalization of drug use, it plays itself out in this kind of dynamic of the stereotypes, ideas, the prejudices, and then the discrimination that occurs. And we still continue to engage in this. Now, what I would like to say also is that as we think about reducing stigma, as we think about sort of reducing our own attitudes and working on our own sort of prejudices and stereotypes, that we need to combine it with empathy. That's an important piece here. We need to be aware that people who struggle with addiction can be harmful at times. To themselves, certainly, but to others, where they may, for purposes of needing drugs, they may lie, they may steal, they may harm someone else. But we have to appreciate and understand that a person may be feeling desperate, and that they're engaging in this behavior out of desperation. And so this notion that hurt people. And so by sort of, along with sort of reducing our own sort of negative views and attitudes, we have to combine it with a stance of empathy towards those individuals. Next slide. So stigma is the belief, discrimination is the action. So what I'm going to ask participants to do and then, is to think about the context of their work, because in a few minutes, we want to sort of ask you how you feel it manifests itself, both maybe from your own personal experience or from the agencies or the organizations that you work with.
Thank you, Joe. So when we think of stigma and we think of harm reduction recognizes that stigma is part of the world, right? And there are ways that we can manage and challenge stigma. And I'm sure you probably have thought of those and probably are managing and challenging stigma on a day-to-day basis. We also know that stigma changes over time. So I want to ask folks to type in the chat box. What is one example of stigma that has changed over time? In the past 15 years, what is something that we have seen that used to be stigmatized before and now is commonly accepted as mainstream? What would be one example? Whoever gets there first. Marijuana, Carissa, yes. 5 points. Yoga, MIT treatment, needle exchange, marriage equality, right? Access to medication assist, tattoos, yes. You're fast typers. Absolutely, yes. I see some great things there. So those are really great examples of the way that stigma changes over time, right? And stigma changes over time because of advocacy and work that people do to shift that. We also know that stigma will intersect with other forms of marginalization and oppression, right? And that those compound. And so we need to be really mindful of those. As well as when we're challenging stigma, we need to try to meet all people where they're at, right? A premise of harm reduction is meeting people where they're at, right? And sometimes that can be challenging, right? But it's part of the work. And sometimes it means that I may not be the right person to meet that other human where they're at, but a colleague, a friend can do that, right? So that's a good reminder for us. We also acknowledge that change is difficult and values are incremental in change. If I think back at myself when I was a youngin', many years ago, and I think about the way that my mindset has changed, my experiences have changed also, and that has impacted the way that I view the world. I had many mentors and people around me that had gifted me the opportunity to be in community with them and really be in profound reflection about my life and my work and who I am, right? And so, you know, change is hard. Sometimes there's things that are part of who we are that come with us, you know, that are normalized in our communities and society that go against some of these principles that Joe and I are talking about. So it's completely normal to feel that we're pushed to that growing edge. What I'm going to ask folks is to take that invitation to move into that space of uncomfortability, right? Because it is in that space that we can grow and learn from each other, right? And finally, one of the things that I have learned is that language can reinforce stigma, both among clients and providers. And so I think in our next session, that will be happening a couple of weeks from now, we'll be diving deeper into this. How do we look at language and how do we are mindful of the way that we use language and how that can create barriers or reinforce stigma when we're working with participants. So if you're interested in that, be on the lookout for that because it'll be happening. And so if you look at this slide here, this is something that I want you to tell me if you've heard these things from your participants, right? These are some of the ways that stigma shows up and creates spaces of discrimination where people are discriminated against. So I've heard participants tell me, yes, Danny, right? People judge me because I'm a sex worker. Healthcare workers don't trust me. They just think I want drugs, right? I've had participants go into an emergency room because they actually were hit by a car and their leg was broken in 4 places. And they were kept in the emergency room for more than 36 hours without any pain medication because they thought they were drug seeking. And this is a human being who actually was hit by a car and had lesions, like a broken leg in 4 places. And that to me is a violation of human rights, right? But these things happen, and they happen to people who use drugs every day. I get arrested for drug use instead of helping me find ways to cope. Sometimes I don't have a place to live, or I have to live in places that are not safe for me, right? Without access to clean equipment, I have to share, and sharing scares me because I don't want to expose someone or contract something, right? And there are no friendly healthcare services where I live. And if we think of this being compounded, what about folks that not only use substances, but may engage in sex work, or folks that use substances and their primary language is not English, right? Or folks that use substances and may identify or have trans lived experience, right? What would that mean for that person, you know, to go into those spaces and not necessarily have access to services that recognize their full humanity and who they are, right? So I see that some folks have shared that these are things that they've heard from participants. And these are some of the ways in which we can hear from folks' narration about their experiences, how stigma shows up. And now I'm going to pass it back to Joe, who's going to move us to the experts corner.
So thank you, Tanagra. I wanted to follow up on a comment that you made about the change process. That I think that's also, and I mentioned earlier that you know, this harm reduction perspective in conjunction with motivational interviewing is really important. And for us to think about the stages of change in working with people and realize that it's a fluid sort of process. And also that while somebody may be interested in change in one aspect of their life, they may not be interested in change in another aspect of their life. And so that we have to keep that in mind in terms of then how do we work with them collaboratively around what they want to change. So we'd like to open it up here to ask you all, how does stigma show up in your work? Again, whether it's your work with participants, clients, and how does it impact on your ability to connect with participants? So sometimes, and I think people in the chat made reference to this, that you may want to do a harm reduction sort of approach, but the system, the agency, the organization that you work with is not is kind of not set up for that, or doesn't want to do it, and has a lot of prejudices about it. So just, it would be if people could just comment about these two questions.
Is it all right if I share, or did you want it in the comment box?
Sure, Malcolm, go ahead.
Okay, yeah. So in the workplace setting that I'm in currently, this experience was very different for me, where a patient had IV medication and they could not go home because of the needle and the PICC line in their arm. And I didn't even think about that, but how I could see that as, I mean, in some ways, maybe that's harm reduction, but also in another way, that's like stigmatizing for this individual, like you're on this medication that you need to fight what's happening to you. And these medical professionals have made a decision for you that you cannot go home with this, which, I mean, she may or may not be aware of, the client, but that's just something that just came up to me. It was a new experience for me. And I was like, in the setting that we that term is used a lot, like they're either med seeking, right? Right. That's another thing that was just, yes. Yeah, just mindful of our language in the medical setting, especially since I'm a social worker in that setting. These things were just very new for me, and just being cognizant of those things.
Great, thank you. Thank you for your comments. There are a number, quickly reading through, and a lot of people giving feedback, which is great. There are some references to medication assisted treatment, and even though there's been some change, people may be familiar. It came out, I think, within the past 6 months to a year, how a lot of inpatients still do not offer medication assisted treatment. And so again, the stigmatization, even within the treatment community for these things. And I remember having a conversation with someone, actually my nephew, who I made reference to, has struggled with addiction, opioid addiction, and he was in a treatment center, and the clinician not wanting or was discouraging the use of Suboxone in the community for him. It's just, you know, it can still be mind-blowing.
Yeah, there's some really good comments in the chat of folks expressing how not only stigma, but how it shows up, but also how it impacts their ability to do their work. And these are great. And also frustrating that these are happening, right? I'm grateful for your participation, but also I wish that you didn't have to go through this.
Right, right.
Thank you, everyone. Thank you, everyone. Joe, is there anything else you want to add before we move to this piece?
There was although again, that's a whole other, probably a whole other topic, but again, the issue of people who are experiencing ongoing chronic pain and their stigmatization, again, often referred to as med seeking and not appreciating that the pain that they may be experiencing. And so I think that's certainly, and again, I've worked with a couple of clients where that's been an issue, so.
I also saw a lot of folks sharing that there's an intersection for folks that work in offering housing services and navigating, supporting people who are unhoused, and the barriers that come up for housing for folks that are actively using, right? That our folks have shared here. Also, the challenges with working with adolescents or younger folks as well, and particularly in those settings. For those of you that are working with folks that are adolescents or younger, there's a really great curriculum. It's a beautiful curriculum that was put together by the Drug Policy Alliance as an alternative to their called Safety First. I think we can link it to the resources. It's a really lovely harm reduction based curriculum to help us engage in honest conversations with folks that we know as adolescents. I mean, it was a long time since I was an adolescent, and but I do remember that development stage, right? Which is we want to be independent. Impulse control is not so good. We want to try things out. We want to be an individual, meaning we don't want to be like our parents, right? But we also want to be part of the group, and so we're navigating this really weird state where our hormones and all this stuff is happening, and we're naturally curious, and so our friends are doing stuff and we want to try to do that too. And I think that curriculum creates space for conversations around that without really shaming or scaring folks. So if you're in one of those settings, I would encourage you to look at that resource. You can also reach out to me and Joe afterwards. I'd be happy to talk more about it. But I just wanted to name that because I saw that come up also in the chat. And there's also really, there's a lot of stuff that we're trying to do. We have some resources on our webpage around homeless, housing first and harm reduction that we can share too, for those of you that are in those settings. And so,
Tanagra, sorry, one more thing, and then is actually your comments about adolescents. The other thing to consider is educating family members around harm reduction. And, you know, and again, that can be a real challenge, especially if they're living with that person, but educating them around sort of what harm reduction is and how they can approach it with their family member who may be using. Sorry,
Absolutely.
thank you.
No, thank you for that, Joe. And so now I want us to think about the forms of stigma, right? The way that the ways that the stigma can show up in life and in our day to day. We can see stigma from individuals. And I don't know if you've heard this, but I used to work at a drop-in center when I used to live in Massachusetts. Back in the 90s, I used to work in Holyoke and we ran a drop-in center in the community. And a lot of folks came in through that space, many folks that were in active use. And I remember hearing conversations such as, well, at least I'm not shooting up, or, well, at least I'm not a crackhead. Yeah, at least I'm not nodding all day, right? And so it was so interesting to me because I used to say to folks, hey, you know what? The reality is when people look through that window, all that they see is the same, right? And so in that sense, it's like interesting, right? That folks would be sort of have a hierarchy, and that hierarchy would lead them to stigmatize some folks because of their use or the way that they use their drugs versus others. So there's stigma from individuals. And then there's institutional stigma. And I think that Joe started addressing some of this. And I think you certainly have addressed some of that in your comments in the chat box. There is very overt institutional stigma, right? And there's also institutional stigma that we don't realize is stigma until we see how it is impacting people differently. For example, I work for the National Harm Reduction Coalition. And 5 years ago, almost 6 years ago, when our new executive director, she was new at the time, no longer new, Monique Tula came on, she was reviewing our health insurance coverage. And she found out that our health insurance coverage did not cover medication for medication-assisted treatment or medication for opioid use disorder. So we had colleagues on our staff who were paying out of pocket, is that how you say it in English? Out of pocket to receive that medication, right? And so that is a way in which folks were stigmatized. We should find health insurance that covers that and people don't have to ask for it. Right. So that's one example of institutional stigma, right? That wasn't intentional, but yet it was happening. It was impacting people. And then I think for me, the most pernicious forms of stigma is self-stigma, is when we hear participants that have internalized these messages that society has about people who use drugs, that they're dumb, that they don't care, that they're selfish, that they're not to be trusted, that they're not good people, that they will amount to anything, that they're a failure, that they are selfish, that they are liars. What else have folks told me that they've heard? That they are better off dead, right? All of those are things that folks that use substances have heard from society, from people around them, and they have internalized that. And that can be a huge barrier for people to then feel that they can ask for things that they need, that they can seek support or seek services because we feel we don't deserve them, right? Because we haven't done good things to deserve those. There is a moral sort of failure component to this piece that is a huge barrier for people. And it's really damaging because it can lead to death for folks. And then finally, stigma through association, right? It's like, if I am in a community where folks use drugs, then I may be perceived as someone who uses drugs, or if I have a family member who uses drugs and the community knows me, then I will experience some of the same stigma that my loved one is experiencing, right? So we have these forms of stigma, but there's also connected to these key elements of stigma, right?
So,
And
Tanagra,
yes,
sorry,
yeah.
This association,
Mm-hmm.
just to quickly, so when you made reference to family members, I know a few years ago when the overdose deaths were increasing, I remember a segment, I think it was on NPR, where a family member decided to put that the person was struggling with addiction in the obituary and not keep it hidden or secret and that sort of thing. So yeah. I just wanted to make that comment.
Yeah. And that stigma, thank you, Joe. It reminds me that stigma through association also contributes to our inability, if we lose a loved one, to navigate and deal with our grief, right? It's disenfranchised grief, is we can't really honor and speak to our loved one in the way that we would want to, because we fear that there will be judgment, right? coming from society because of who they were. So it's really brave that that person did that.
Yes.
Right. And if we have disenfranchised grief, then we are not able to process it, right? It's not like grief goes away, as we all know. We grow around our grief. Our grief grows around us, right? And we learn how to live with it. But it's much harder to live with it if we feel we have failed that person because we couldn't honor them the way that they would have been. Because people are not their behaviors. People are human beings that are full human beings, messy, beautiful, complicated, and they're certainly more than their substance use as well. So when we think of the key elements of stigma, these are the underpinnings of stigma, right? These are the things that keep stigma in place. Right? So we see a lot of blame and moral judgment around people who use drugs, around people that engage in sex work, right? Well, you know, why are you complaining? You got yourself in that position in the first place. If you weren't using drugs, you would not be out of a job, or you wouldn't be unhoused, or you wouldn't be on probation. We criminalize people who use drugs. We have people follow them. We don't trust them. We don't trust them with money. We don't trust them with their own process of recovery. We don't trust them to work with us and develop work plans in partnership with us. I have had participants be followed by staff in clinics, and they have felt really offended by that. And there's other ways in which we criminalize people who behave in ways that are different or deemed bad in society, right? We also pathologize and patronize people. We don't think that people that use drugs are capable. So we think, you know, for them, you know, they're not able to do what they need to do. So let me do it for them, right? And this is also something that hinders people's ability to tap into their self-efficacy and their ability to tap into their power and to make decisions. And finally, there is fear. Yes, Brittany, self-bigotry, absolutely. And then we have fear and isolation, and this leads to death, right? This leads to death when people are unable to speak to the things that are happening to them or what they're living with. If they feel that if they share their substance use or their struggle, that they will be judged. What that leads is to people retreating into themselves. And we know that things that go into the shadows and the silence is what actually kills people, is what leads people to be more hurt and more harmed. I think a lot of the work that we do would be different if we would create safe spaces for people to come to us and tell us, hey, I have been struggling with this, or I am using this, and I feel that I no longer have control over it the way that I had it before, and I feel concerned. Right? If we, as a teenager, have been able to go to my parents and say, hey, you know, smoking that weed made me feel real good, you know, and it made me calm down, and it made me forget my nervousness and my anxiety. Maybe it wouldn't have led to other behaviors that were unsafe for me, but I couldn't, right? And so because I couldn't, you know, then there were consequences for me. And so I think when we think about fear and isolation as providers, I would ask us to really reflect on the ways that we perpetuate that in our practice, by silent judgments, by overt judgments, by really not listening truly to what people are asking or needing from us. And ultimately, stigma keeps people out because it points to people's perceived differences. It keeps people away by making us think that people that use drugs are dangerous and they cannot be around us. And finally, it keeps people down by discriminating them, right? By judging them, by making us think that that difference is bad, right? And it's to be dangerous. And so what we want to do is look at this cycle of drug-related stigma, because we're going to look in a second at a way that we can break this cycle, right? There's a cycle of drug-related stigma that we can break. And so in order to break it, we need to understand it, right? And so stigma starts with stereotypes and labels. And this is why language is so important. Language constructs our reality, right? Language constructs our reality and perpetuates notions and ideas that we have of others and ourselves too. And so when we think of stereotypes and labels, right, I just want to ask some folks, if you want to throw in the chat box, what are some of the stereotypes or labels that you've heard people around you use about folks who use drugs? What are some of the things you've heard? They lie. Yeah, they're not trustworthy. Thank you, Lacey. They're weak. They're helpless. They're lazy.
Will
They
never
can't control it.
change. Yep.
Yes, they steal, right? They're on how they're bad parents. Yes, absolutely. They're houseless. Yes, they're selfish. Yes, Lacey. They're dishonest, manipulative. They're not going to change, right? They're weak-willed, always an addict. Once an addict, they disappear. They're bad people. Absolutely, all of those things. So if that's what I'm hearing, right, and I see things are morally bankrupt, yes, Suzanne. So when those things, you know, you hear those things, you internalize those things, then I'm going to behave in the way that you expect me to behave. I'm going to assume that role, right? Because now you think that I'm not good, right? You think that I'm lazy. You think that I'm weak. So why am I going to try to change your mind? So I'm not going to show up for my appointments, or I'm not going to do the things that you told me to do. I'm going to drop out of the program, right? And that means that then my opportunities become limited, because what happens? There's a word that we use that I wish we would do away with folks that come more than 1 or 2 or 3 times to our programs. What is the name of that word? Participants recycle. What's the other word? There's a word that we can use. I'm looking for it because I can think of it in English. They're non-compliant, frequent flyers. Yes, there's another word, right? That they keep coming back, right? And so reincidentes, that's what we say in Spanish, right? They come back, recurring, yes, Emily. And so that means that limits people's opportunities, because then what happens? I'm not, as a provider, if I think that way about someone, I'm not going to put much work in supporting them, because I know that in 2 days they're going to drop out again, right? And so, yes, I'll type it in English, and recidivism, yes, I'll type it in Spanish. And so those limited opportunities are really damaging for people, because then this beliefs that people have about themselves, those expectations and roles become internalized and reinforced. So then they become stronger. And then the cycle stigma starts again. It's a push and pull. Participants are expected to behave in one way. They behave in that way. The providers then behave in the way that they're expected to behave to counteract that. And then this cycle continues to be reinforced and internalized. And it develops really profound, strong roots that we need to pull out completely to be able to shift and change and build new systems, right? And new cycles. And so, yes.
Tanagra, can I add just
Everything.
a comment about stereotypes and labels? Again,
Yes.
What I'm putting this in the context of cognitive, sort of therapy and cognitive approaches, but I work with people around anger, and one of the kind of the thinking distortions is labeling people. And what happens, even if you don't say it out loud, what happens is, even if you're thinking they're useless or they're worthless or they're bad, is it makes them less than. And by making them less than in the context of, as I talk about it with anger, it makes it easier to be angry and aggressive. But in this case, it makes it easier to be discriminatory and prejudiced, because they are less than. And so why would you treat them in any with any equality or compassion, because they're worthless.
Exactly.
So just a thought there.
Yeah, thank you for naming that, and how pernicious dehumanization is, right? It's really easy to treat someone poorly, treat someone in the ways that you've named, if I don't see them as full human beings, right? And so that's what stigma does. And so what we want to do is shift that. We want to build a climate of trust, right? Because a climate of trust will ensure that there's positive outcomes, not only for people who use drugs, but for their communities, which are our communities. People who use drugs are amongst us. We are here in this room. We're part of your communities, right? And we want positive outcomes, not only for ourselves, but also for people that live around us, right? What is good for people who use drugs is good for communities, right? So we want to create space to build those positive outcomes. And the way that we do that is by developing interpersonal linkages, right? One of the things that stigma does is it isolates people. It separates people from each other. And so we want to do is create spaces where there's interpersonal linkages, where people can start feeling that they're seen as people, and that they're welcome in those spaces, and that they can connect to others, right? That may share also their same experience, that they can be in the same spaces with folks that where they can see themselves and see others, right? And that they can have the support that they need and the resources that they need. And so in order to do that, we also need to start building or creating an organization of climate of trust, right? So how do we do that in systems that tell us that we need to pack that abscess really, really hard so that that person learns their lesson and doesn't come back again? Whoever has had an abscess knows that the process of taking care of it, all of that process can be really painful in and of itself. So to think that a provider would say that on purpose and say that they actually would do that to teach a lesson, right? That doesn't build trust. So how do we create an organizational climate of trust, right? How do we do that? So we do that by telling people that we welcome them and actually welcoming them, right? We look at our policies and practices to see the ways that we're keeping people out and keeping people away, the way that we use language. What are the rules and regulations that we have in place, right? And how can we look at those and keep the things that are working, but also shift the things that we know are not working, right? Because that helps us to build systemic trust, particularly when folks have experienced stigma in regards to their substance use. A lot of folks don't trust us because we are part of those systems. I had a participant once tell me, so you told me that this will be different, but how is it going to be different? You need to prove me that it will be different, because you know how many times I've heard people tell me that they're going to help me and then they end up kicking me out to the curb. You know how many times I've been told no, how many times I've been pushed out, right? So building that systematic trust is really important, and it's a commitment and it's a practice. And it's not a perfect practice, right? There will be times where we will feel that we're failing, that we're not doing things right. And that's the moment to stop and ask participants, what is not working and what can I do differently to make sure that this is a safe space for you? And if we do that, then we create a space of cultural safety, a space that is safe, not only for people who use drugs, but all the other participants that are part of our services. And also for us as people who are in relationship with clients or participants that use drugs. And so building this virtuous cycle of trust is really important, but it takes a lot of work and a lot of unlearning, as Joe was saying, a lot of unlearning of things that we have been taught, a lot of stepping into brave space, and a lot of going, ¿cómo se dice? Something in a prayer. There's a saying, I forgot how you say it.
A wing and a prayer?
A wing and a prayer.
Yeah,
sometimes,
yeah.
Harm reduction, sometimes you got to brace for the unexpected and be flexible and be open to learning and work from that place of empathy and care and love for this other human being who's in front of me, who happens to use drugs, but also happens to be a great softball player, an amazing writer, a great musician and cook, right? And also a person who has used substances and has done some harm to themselves and others. But we have to remember that people who use drugs may harm others, but people that don't use drugs harm people all the time too, and we don't judge in the same way.
Right.
That's a good reminder for us,
Yeah.
right?
Yeah. Okay, so what does it mean to dismantle stigma? What we would like people to think about is to consider an action plan for themselves with their agencies as they move on from this webinar. So next slide. So really creating change means dismantling stigma at the individual, organizational, and community levels. And so what I'm going to focus on, and then Tanagra will focus on sort of the organizational community, is the individual level. What I would say is for social workers who don't have a lot of experience, and I know a lot of people on this webinar do, and I think that's wonderful. But for those social workers who don't have a lot of experience working with individuals with substance use issues, is not to quickly decide to refer them out. I think that sets individuals up for failure. Tanagra was talking about barriers. It's just another barrier that they have to find someone else. So to really be aware of that. For any kind of therapy to be helpful, it's a matter of developing the therapeutic relationship So it's important to leave oneself open to a dialogue with that individual, to be curious, to discover what they're dealing with. And what I would say, over the past 20, 30 years, we've talked about being trauma-informed clinicians. We need to be substance use-informed clinicians. We can't get away from it. And now more than ever, I think it's just really, really critical for us to be substance use-informed clinicians. We need to monitor our language that we're using. Also, how our clients may talk as well, even those who may not necessarily have their own substance use issues. So I'm working with a client who has referred to his mother as a drunk. Now, both his mother and his stepfather were very abusive. They were physically, emotionally, and verbally abusive to him. And so he's got a lot of resentments, and that's what we're working on. But, and I was able to have a sort of an in saying that calling your mother a drunk just sort of intensifies the feelings and keeps you really from getting some distance and maybe some empathy for her. As he's still trying to negotiate a relationship. So sometimes it's a conversation with people around, again, they may not have a direct issue with substance use, but they're in contact with somebody who is, and talking to them about the language that they're using. I would also say that we have to be aware. So I talked about empathy being important, but we have to be careful about an empathy hierarchy, where we're going to be more empathic towards certain people and less empathic towards others. And so I had heard that in a podcast I was listening to a couple of days ago, and I just found that really useful. And just for our own sort of work that we're doing in working with clients is to be aware of that empathy hierarchy. The other thing I would say is, and this kind of is a bit broader and goes into organizational and a community, but there have been a few times where I've read an article by a journalist, and they use language like substance abuse or addict. And so writing, in these days, it is easy to email someone and say, please be conscious of the language that you're using. And so sort of doing that advocacy, I think is also important. And obviously getting constant education and personal development.
Thank you, Joe. Now I'll walk us through both organizational level and community levels. What are some of the things that we can do to begin to consider or work towards dismantling stigma? So again, training and education, right? I think it's really, really important, particularly if we work within bigger, larger structures. It can feel really frustrating when we are trying to do things differently, but the organization is going in a different direction, right? Because that can be really challenging, not only for us, but also for participants that are receiving services in other areas of that organization. So we really encourage organizations to think about training, creating spaces for training and education for everyone. I say harm reduction has to start at the very front door and go all the way to the back to human resources and administration. Because if I have someone in human resources that doesn't understand what I need to give to get cash to pay participants for their work, then that is a barrier, right? Participants are not going to be able, if I have an administrator that doesn't understand that we may need to write grants differently in order to be able to use different language, in order for us to be able to pay participants for their expertise or to engage them or to hire them, then we are not, we're having challenges around harm reduction, right? And challenges in regards to dismantling stigma. And so that's really, really important. Also having outlets for feedback, not only for participants, but for us as members of the community, right? I think that that's really, really important. I always ask participants when I work with them, what am I doing right and what can I do better? And I have to be ready to hear what I can do better, right? And sometimes I have had to go back and realize that I wasn't my best day, and to say, you know what, I apologize. It was not my best day, and I didn't like how I showed up in that space, and I want to try to start again, or can we pause for a second, right? And thankfully, I've had really good relationships with participants to be able to do that. And so thinking about those outlets for feedback, that they're constant, that they're open, that we encourage people to give us their feedback because they see us not only listening, but taking it and applying it, right? An assessment of our practices is also super important. You know, what are things that I was just saying we're doing that are enabling people to access our services fairly easily, right? Low threshold. And what are the things that we have set in place that are keeping people out because they're asking folks to jump through so many hoops that is almost impossible to get to us, right? And so that is also really important. And ultimately, you know, we want to hire people who use drugs. We want to have people who use drugs leading organizations. We want to have people who use drugs you know, at every level of organizations. I know many folks in different parts of this country who run organizations successfully for many years, where people who use drugs, and they are very successful in the work that they do. And so I think we need to begin to demystify sort of this myth that people who use drugs are not able to do these things because we can. And
Sorry, Tanagra,
yes.
One thing about the organizational.
Yeah, you want me to go back?
Yeah. So I like the front and the back door.
Yes.
And although it's still happening, but administrative staff, who is meeting the person at the front door.
Yes.
And you could be the best harm reduction therapist in the world, but if that person is kind of negative, that's going to set a wrong sort of environment for the person. And then outlets for feedback. There's also, and some of you may be familiar with Scott Miller and his talk about feedback informed treatment, is for us as clinicians to constantly be asking, you know, how am I doing? Is this helpful? What isn't helpful? And to have that dialogue. Thank you.
Absolutely. Yes. From the front to the back, everybody should be a harm reductionist. Yes, absolutely. Yeah. And that helps us because when we think also about the work that we can do at the community level, you know, we want to encourage the development of participant advisory boards that are truly engaging participants, and that they're actually taking in their advice and we're using it, right? So it can be tokenizing. It truly has to have a purpose to really hear those voices to inform our work and the work that happens in the community. Awareness campaigns. I remember before, when we could travel in 2018, I went to North Dakota to do a training, and they were so excited that we were there because it was their first ever AIDS walk that was ever going to happen in North Dakota, in Fargo. And so they were thrilled. They were psyched. And this was an awareness campaign. So I think awareness campaigns, what they help us do is to sort of push back on stigma, because it normalizes these conversations, right? And it shows, you know, that yes, there's people that are among us that live with HIV. There's people amongst us that live with Hep C. There's people amongst us that are really bad singers. And that if I sing in the shower, you will probably start hearing the drops of rain because the sky will split open, asking me to stop, right? And so it's thinking about building awareness campaigns, engaging in policy and advocacy. I love that social workers, we fight, we're scrappy, we get involved, particularly when there's policies and practices that are being pushed that will harm people that we care about. And people in the community in general. So being mindful of what is going on and how you can support it is really important. And also building collaborations with partners and showing up to events. You know, we worked with a program in Montana that was the first harm reduction program there. And every Thanksgiving, they are in a main street. They close down the main street and they collaborate with different community partners to have like an open house of their different programs. And that is a way that people can go into the harm reduction program and see what it is. And a lot of folks think a harm reduction program, you walk in and syringes are going to jump out at you. And the reality is that when people walk in, they said, oh my God, this place is beautiful. It's so warm. It's like a house, right? And they realize and see that this is just a space that just holds people and cares for people and gives people a space to feel loved and seen and heard, right? And those folks then become supporters of these programs. And then they start thinking and speaking differently about people who use drugs and their experience. And so now I'm going to pass it to Joe to bring us to the final,
yes.
la meta.
Yes. So one comment I wanted to make, there were a couple of comments in the chat a little while ago about co-occurring disorders. And again, the ongoing issue around that. I think it's changed, but ever so slowly, but we still have a lot of silo kind of approaches that, oh, okay, if you have a primary mental health, you got to go there. If you have a primary substance use problem, you got to go there. And really, given the interplay between the two, we need to really promote the notion of integrated treatment. It just is not helpful to kind of keep people in these different silos. And again, I think it's another barrier to treatment. So for the sake of time, we would really like to hear from people about one strategy that you can use starting this week to move towards dismantling stigma as a provider, either through yourself or maybe interfacing with your, interacting with your agency or organization. So use more accepting language and encouraging coworkers to do the same, reminding people to be mindful of language. Great. Again, the language really important. Remember to be more curious. Great. Sharing the concepts from the webinar. Great. Seek feedback. Yes, yes, yes. Voter registration. Yes. Caution with jumping to assumptions, challenging policies that create barriers to accessing medication-assisted treatment. Follow up with calls, great.
These are also great.
Yeah. Keeping an open, non-judgmental stance.
I'm really glad that we get to keep the
Show compassion.
transcript, so
yes,
we can lift and pull some of these out, you know, from here, because they're really great. Thank you, everyone.
Empathy. Yep. Trauma informed. Yeah, the rate of trauma and substance use is so high. It's incredible.
Yeah. So I think we're coming to a close, but before we're gonna have some time for folks to ask questions. I think we have about 5 minutes, and but don't panic, because we will have an office hours, which is a space where we're hoping you will join us and we can dive deeper into some of the things that you've asked in the chat box, but also some of the things that you've shared here. So if that is something that interests you, Joe and I will be there. They are on May 12th at noon Eastern time. So make sure that you are in the lookout for those. And we are going to, Joe and I are taking our show not on the road, but we will be back together with a second part to this session. Maybe one of these days, Joe and you and I can take it on the road.
Right,
really on the road. So the second program session is, do I need to be an addictions expert, engaging and supporting people who use drugs? And those that will be happening on May 19th from 12 to 1:30. So if you liked our faces and want to be in community with us again, please join us for that, and for those office hours. I'm going to stop now and see if there's any questions that folks are sort of like really itching to ask before we close.
Could you give us the dates of the conference in Puerto Rico?
The dates are from the 13th to the 16th.
Of which month?
Of October. October.
Okay,
yes.
thank you. Thank you.
Of course, yes. Thank you for asking. CE codes. I think that's Chris Belli. Joe and I are not in charge of the CEU codes. Actually, if it's okay, I'm going to stop sharing so I can share the slides with folks. Would that be okay? Okay, let me stop sharing so you can get those. Give me 2 seconds, folks, because I need to stop here and to share.
And again, any questions? I'm glad people have really appreciated the webinar.
So that's the link to the slides. And we will add some of the resources that Joe mentioned earlier in there too. But at the end, you'll see that we have a whole list of resources for you on different topics related to this work. And so peruse them, check them out. If you come to the second session or to the office hours, let us know what you thought of those. And if you have any feedback for me, please don't hesitate to reach out directly and let me know. You have my email. I always welcome, any feedback that you may have for me as a trainer. Thank you so much for letting me be in community with you.
Thank you.
evening.
Yes, ditto for me too. If there's any feedback you'd like to give me, please let me know.
Oh, there's a question for you, Joe.
Oh.
This says, Joe, you mentioned earlier a reporter that used the term substance abuser. Is a more correct terminology a person who uses drugs or something else?
So substance use, you may want to specify a person who uses opioids, person who uses marijuana, person who uses, so separating, abuser. And there's a guy at MGH who's done a lot of studies about changing the language, even changing substance abuser, which has a lot of negative connotations, to person with is a better sort of framework.
Yeah, and there's a question here from Sarah that is sensitive just to smells and fumes in general, and it's asking how they can sensibly communicate the needs around that, because we want to be in a space and not feel sick. And so how can I let people know, hey, I don't mind you smoking, but please, do it somewhere else because it makes me sick. I guess like that, maybe. I don't know, Joe, do you have any other suggestions?
Yeah, no, I think to be sort of genuine and transparent and not do it in a way that shames the other person or is making the other person feel like they're doing something really bad. Yeah. But yeah, just separate what they're doing from their behavior.
Mm-hmm. Thank you.
Thank you.